Good evening, everyone. Welcome to this presentation on Mal de Débarquement Syndrome, which is abbreviated as MdDS. Imagine returning from a wonderful overseas journey, 9 flights, a relaxing sea cruise, road trips, and Eurail, only to discover that the ocean has come home with you. The solid ground beneath your feet continues to sway and rock long after the ship has docked. This is the reality for many patients with MdDS. In today's talk, we will discuss a compelling case of a 44-year-old woman who developed persistent rocking, swaying, and bobbing sensations within 48 hours of her return. Despite a normal cervical and brain MRI, blood tests, and most vestibular examinations, her symptoms significantly impacted her daily life, yet improved dramatically with targeted treatment. MdDS is a persistent perception of rocking, swaying, or bobbing motion after exposure to the passive movement like cruises, flights, or prolonged travel. Symptoms often ease temporarily while in motion, such as driving, but worsen when stationary. It is frequently underdiagnosed, predominantly affecting middle aged women. MdDS beautifully illustrates the persistence of ocean swell beyond the time spent on the cruise, just as the rhythmic waves of the sea continue to echo in the body and mind long after disembarkation. The adaptations, experiences, and turbulences of our lives often linger within us, shaping how we perceive and navigate the world long after the original journey has ended. It reminds us of remarkable plasticity of the human brain, its capability to adapt, and sometimes its reluctance to go off a rhythm it has internalized. Today, we will explore the clinical features, diagnostic criteria, underlying pathophysiology, and especially the promising optokinetic head roll protocol that brought rapid relief in our case. Thanking you for joining. Let's begin here only. So, this is my title slide, Mal de Débarquement Syndrome. From there in after, I will call it as MdDS. Case history: 44-year high profile lady, no past medical or surgical history. Presented in May 2026 with 4 months history of subjective unsteadiness. Body sways which were up and down, side to side, forward, backward while sitting, standing, walking, and even during lying down. Symptoms were absent while driving, but severe difficulty in braking or stopping cars. She would not like or prefer to stop the car whenever she desired, and this led her to fear of driving car. Difficulty in turning, especially while taking out the objects and edibles from the refrigerator. She would prefer to retro walk due to fear of falling while taking edibles out of the refrigerator. And there was a directionality here. It was more difficult to turn right than to the left. However, most of this time she would walk retro and then slowly keep the objects on some table or in the kitchen. It started within 48 hours of returning from an extensive overseas travel, including 9 flights, 4 night sea cruise, and road and Euro rail. Before she consulted our neurology services, her MRI brain and cervical spine was done in January 2026 were normal. Routine blood tests, including the blood sugar, renal function test, and liver function test, thyroid profile, electrolytes, vitamin B12, and D3 levels were within normal limits. Examination and treatment. Neurological examination revealed normal mental status, cranial nerves, motor power, gaze holding and pursuits, and smooth pursuits and saccades. Vestibular test, normal head impulse test, positional test, no head shaking nystagmus, no hyperventilation induced nystagmus. Fukuda stepping test, she rotated her more than 45-degree to the right before the completion of 100 steps. Our diagnosis was clear cut Mal de Débarquement Syndrome. Treatment we gave was the optokinetic head roll in this patient. Outcome, her DHI score improved from 48 to 10 in less than a week. So, what is MdDS? MdDS is a persistent perception of rocking, swaying, or bobbing motion after exposure to the passive motion like sea cruise and travel by flight, train, or even by the car. Symptoms worsen on standing still, lying, sitting, climbing upstairs, coming downstairs, and turning while walking. Symptoms often improve temporarily during re exposure to passive motion such as driving, vehicular travel during flight, and in the train. There is phantom perception of persistent rocking, swaying, or bobbing sensation. Symptoms are aggravated by standing still or lying quietly. Temporary relief with passive motion. Imbalance and unsteadiness is present, mostly subjective. Fatigue, cognitive difficulties like brain fog are often experienced. Anxiety, depression, and sleep disturbances may be present. So, what are the criteria? The Berenice Society laid down the criteria for MDDS in year 2020. They were published in the Journal of Vestibular Research. A. Non-spinning vertigo characterized by an oscillatory perception, that is rocking, bobbing or swaying, present continuously or for most of the day. B. Onset occurs within 48 hours after end of the exposure to the passive motion. C. Symptoms temporarily reduce with exposure to passive motion. D. Symptoms continue for more than 48 hours. Now, the D is divided into three different categories. D0 MDDS in evolution means symptoms are ongoing, but the observation period has been less than 1 month. D1 is transient MDDS. Symptoms resolve at or before 1 month, and the observation period extends to at least to the resolution point. And D2 is persistent MDDS. Symptoms last for more than a month, and that was the case in our described case. E. Symptoms not better accounted by another disease or disorder. So here I have animated this, what is phantom bobbing, and this is all the subjective feeling. You can see it here. The subject feels as if he is being pushed up and down by an invisible force, and this is invisible to others as well. So this sensation is totally subjective, always present, reduced significantly during the passive motion while in the vehicle which is in motion. The another feeling is the phantom sway, that is side to side. As you can see it here, again this sway is invisible to others, totally subjective, but makes the patient extremely uncomfortable. And phantom rocking, this is present while the patient is standing or walking. Fore and aft oscillations, always present whether the patient is standing or even during walking. Walking is an active motion, so it is present. It is an uncommon disorder, frequently underdiagnosed. In our case also, the patient had been from pillar to post, from one neurologist to other, to orthopedician, concerning that it is a cervical problem, and ultimately she landed at our center. Predominantly affect the middle-aged women, and she was a perfect woman for this, having 44 years of age. Usually follows a sea travel, cruises, flights, and prolonged vehicular travel. In this case, the multiple travels by different methods, including the flights, trains, and the taxis, cars were present. Can occur spontaneously without an obvious motion trigger. This is very important that it can occur spontaneously without an obvious motion trigger. What is the pathophysiology? Exact mechanism remains uncertain. Maladaptation of vestibulo-ocular reflex and velocity storage mechanisms in the cerebellum are considered to be important in its pathogenesis. Abnormal functional connectivity in the brain networks, altered sensory integration and neuroplasticity. Treatment, patient education and reassurance, vestibular rehabilitation therapy, benzodiazepines and selective serotonin reuptake inhibitors in selected patients who have lot of anxiety and depression, management of anxiety and sleep disturbances, neuromodulation techniques are under investigations. So this is a coming up therapy which is called optokinetic stimulation therapy, developed from the work of Dai and colleagues, uses moving stimuli with head roll movements, aims to readapt the vestibular velocity storage mechanisms, can significantly reduce symptoms in selected patients, usually performed in the specialized centers which are well equipped and well known for their treatment protocols in this disorder called MdDS. So this is a readaptation of vestibulo-ocular reflex by the optokinetic head roll for MdDS treatment. Mechanism and clinical applications were by the M. Dai et al. In the vestibular research. So optokinetic head roll adaptation. What is the pathophysiology and mechanism? The targeted maladapted vestibulo-ocular reflex and velocity storage mechanism in the MdDS. MdDS maladaptation results in persistent bobbing, rocking, swaying sensation after passive motion exposure. There is a maladapted velocity storage integrator. There's failed readaptation to stationary environment on disembarkment. So how it works? There is full field optokinetic stimulation, moving stripes at the rate of 10 degrees per second, slow head rolls plus minus 20 degrees at the frequency of 0.167 hertz. That is the frequency of our vestibular system. Creates a controlled sensory conflict, drives recalibration of the vestibulo-ocular reflex and velocity storage, opposes the patient's maladaptive bias. This is very important. It is meant to oppose the patient's maladaptive bias. A bias is always present, and which in our case was found to be on the right side. So visual plus vestibular conflict, it results in central readaptation. The protocol involves head roll at 20 degrees side to side, that is the roll movement of the head at the frequency of 0.167 hertz. That is, every 6 seconds the head is rolled side to side. The roll movement has to be of 6 seconds duration. Optokinetic strips are the horizontal stripes direction individualized. Duration is 3 to 5 days. Passive or active head movement. Effectiveness 50 to 70% patients report improvement. Reduction in rocking and swaying sensation. Effects can last for up to months. Supported by sham controlled studies. Best under specialist supervision. I would again emphasize on this frequency. This is the resonance frequency of the vestibular system, and that's why the 6 seconds period is adopted here. Here I have made a video, and this figures me during how to do the optokinetic stimulation in a patient with MdDS who has a bias towards the right that occurred in our patient. This is the optokinetic stripes which are moving right to left. This video I am showing for the management of patients with Mal de Débarquement Syndrome who have returned from the COS and suffering from this syndrome. And especially this is for those patients in whom there is a roll to the right side, that is during the fugular tapping test the patient rolls towards his right side. So this is the screen, you see the optokinetic stripes moving from right to left, and the patient has tendency during the fugular test to roll to his right like this. So he is advised to keep this optokinetic stimulation in front of him from right to left, and now every 6 seconds he has to move his head 20 degrees right to left, and this left to right and right to left roll movement of the head should occur over a period of 6 seconds. So this is done for the patients who drift rightward during the Fukuda stepping test. These are the patients suffering from Mal de Débarquement Syndrome. Usually in these screens there is a click after every 6 seconds. So you need not have to see the watch every time. Roughly the speed should be from left to right 6 seconds. That is the natural frequency of the vestibular system in human beings, that is the motor organs. One thing is that your visual fields should occupy 80% of this screen. For patients who drift leftward during the Fukuda static test, that is the patients with Mal de Débarquement syndrome, the strips should be moving left to right. So usually 2 to 3 minute sessions around 3 to 4 times daily for 5 days. They are effective in around 70% of the patients. Thank you very much. So the resonance frequency in MdDS treatment is very important concept. 0.167 Hz is the natural frequency of the vestibular system, that is the one cycle every 6 seconds. It matches the typical slow rocking motion of the ocean swell. Ocean swell means the ocean waves, common MdDS trigger. Key in the treatment, head is rolled side to side at exactly 0.167 Hz during the optokinetic stimulation, which should be properly selected depending on the bias of the patient. Why it works? It maximizes the readaptation of the brain's velocity storage mechanism. Results in this case, the DHI improved dramatically from 48 to 10. Prognosis, many transient cases resolve spontaneously. Persistent MDDS may last for months to years. Relapses can occur after subsequent motion exposure. Early recognition and treatment may improve outcomes. Key references are from these 4 articles. Thank you very much.